I'm honored to be the monitor of the moderator in this grand round from one of the persons that I consider my brother, Dr. Abdullah AlZahrani, resident from the program from King Khaled Eye Specialist. He was the chief volunteer group. He completed his glaucoma fellowship, and I remember I was already here the 2 complete years. He was chief fellow. Now we have the honor to have you as a consultant, which is great for us. And currently he holds the position of assistant professor at Al Faisal University. I'm great to present him to one of the subjects that I think is the most challenge. We always have this relationship of love and war with retina and glaucoma. And Dr. Abdullah AlZahrani is going to enlighten us. Please, Abdullah, it's all yours.
Assalamu alaikum. Welcome, everyone. Thank you, Dr. Kurrat, for this great introduction, and welcome, everyone. Today, we will address the common issues of elevated intraocular pressure or secondary glaucoma following retinal surgery. This topic has great significance for all ophthalmologists in general, and during this talk, we'll talk about the incidence rate of elevated intraocular pressure post-retinal procedure, and later we'll identify the risk factor associated with high IOP post each retinal procedure, and then we'll go to explore the pathophysiology which can improve our management strategy at the end. So we'll start for the first procedure, parasplanal vitrectomy. So elevated intraocular pressure is common complication post BBV. It is reported from the studies done in 1970 and 1980 from 20 to 60%. And there is one study done in 90s by Nhan Lewis. They found there around 36 of the patient has acute elevated of intraocular pressure more than 30 within 48 hours post-vitrectomy. But at the end of this study, they found there is no significant difference between pre-operative and late post-operative IOP. So in general, the secondary open-angle glaucoma account for 80% of glaucoma post-BBV, and the 20% is account for angle closure glaucoma. There are several variables that are associated with the increase of intraocular pressure following BBV, which include combined BBV with scleral buckle, combined BBV with gas and silicone oil, combined BBV with endophotocoagulation, combined with lensectomy, and also those patients with BVR are more likely to experience high IOP post-op compared to those undergoing for retinal macular hole, for example. And also aphakic and pseudophakic patient, they are at high risk. And of course, if the patient has family history of glaucoma. So we'll discuss also why the aphakic and pseudophakic patient they are at high risk. So we'll discuss this in the next slide. So in the risk factor, we mentioned that aphakic and pseudophakic patient, they are at high risk. But why are they at high risk? In vitrectomized eye, the oxygen tension is rise 3 times to the pre-operative levels. So this increase of oxygen tension in pseudophakia and aphakic patient, it will lead to change in trabecular meshwork that will reduce the aqueous outflow, and it will end with elevated intraocular pressure. In compared to the aphakic patient, if the oxygen tension is increased, it will go for more changes in the cataract. So there is nuclear sclerosis changes of the lens itself. So in general, we have 2 mechanisms, open angle mechanism. As we talked before, it's account for 80%. and also it is caused by uncontrolled inflammation and high steroid responder, and also blood-mediated mechanism. And the angle closure mechanism is account for 20%. It's caused by pupillary block that is mediated by fibrin reaction or cellular body edema or iridocorneal opposition. So in management for high intraocular pressure post BBV, most of the patient, they can be managed medically, and most of the patient without any history of ocular hypertension or glaucoma can tolerate the transient postoperative rise in the IUB. And very important to identify the patient at risk for high intraocular pressure. And if the surgical intervention is needed, it can be in the high cases with uncontrolled intraocular pressure with failed medical control. And if the surgical intervention is decided, the glaucoma drainage device is preferred over glaucoma filtration surgery for like trap or other procedure because of conjunctival scarring. And we should also choose the procedure based on the mechanism of intraocular pressure elevation. So we finish from the BBV, we'll move to the scleral buckle. So the indentation is caused by scleral buckle. It will change the eye geometry with increased likelihood of developing glaucoma. So the occurrence of secondary angle closure glaucoma following scleral buckles from 1.4 to 4.4%. And the incidence of shallowing of anterior chamber without angle closure is higher. It's reaching from 14 to 50%. And the factors contributing to angle closure post-scleral buckles, including pre-existing narrow angles and use of encircling band that wrap the whole circumference of the eye, or placement of encircling band anterior to the equator, and also high myopic patient, and also older patient at high risk because of high risk of anterior segment ischemia. And also postoperative ciliocoroidal detachment, they are at high risk of high IOP post-scleral buckle. So the mechanism behind the angle closure after scleral buckle has been shown in animals models, and the placement of scleral buckle can lead to the impairment of venous drainage, and this impairment will cause congestions of ciliary body, and this congestions of ciliary body will displace the ciliary body anteriorly. That will shift the lens iris diaphragm forward, and that will cause angle closure. So in the management of high IOP post-scleral buckle, in most cases, secondary angle closure glaucoma resolves spontaneously within days to several weeks with medical treatment alone. And medical treatment includes cycloplegia, because we need to shift the lens iris diaphragm posteriorly, and also we need to start the patient on corticosteroid to decrease the inflammation, and also we will start the patient on also equisuppressant. And also you can get benefit from laser iridoplasty in refractory to medical treatment that will cause opening of the angle by facilitating of aqueous outflow. And also we can consider loosening or cutting the buccal in axis high of the buccal. And surgical intervention can be considered if there is permanent synovial angle closure with uncontrolled IOP, and also the same as the procedure of choice post BVV, the GDD is the preferred over trabeculectomy. Now we'll move to the PRP. So the transient increase of IOP following PRP is quite common. 32 to 94% present with transient increase of IOP more than 6 millimeter of mercury, and the IOP spike usually occur immediately within 2 hours. The risk factor is not well understood post-PRP, but higher energy levels are associated with increased incidence and severity of IUB elevation following PRP. The pathophysiology for the elevated intraocular pressure post-PRP, it can be result from open and closed angle. For proposed open angle mechanism, we have decreased aqueous outflow because of compression of the episcleral vein by phalanges of the lens, and also we have decreased uveoscleral outflow because the congestions of the ciliary body, and also we have decreased ciliary muscle tone because damage to the short ciliary nerve. And the pathogenesis behind the closed angle mechanism in the post-PRP is similar to the scleral buccal mechanism. Swelling of ciliary body that will lead to anterior displacement of the lens iris diaphragm. So the management of the high IUB following PRP, usually it is transient. With most of the cases, it will resolve within 1 month. And IUB elevation is usually managed medically. And also we can consider pre-treatment with abraclonidine, but it show compared to the placebo, it is in one study there is no difference statistically. So now we will move to the anti-VEGF injection. So the incidence of use of anti-VEGF can lead to the acute or chronic elevation of the IUB, and 90% of the patient present with immediate IUB more than 30 millimeter of mercury after receiving of 1 injection. And the IUBs approach normal level 30 to 60 minutes post-injection in most of the cases. And incidence of sustained IUB is 3.45% to 6%. The risk factor also here have not been well documented, but it is higher prevalence of the IUB elevation after receiving Avastin compared to Lucentis. So here we have 9.9% compared to 3.1%. And also the other risk factor, of course, if the patient has pre-existing glaucoma, and the incidence of sustained IUB is also related to the frequency of intravitreal injection. The pathophysiology here is related, the acute elevation is related to the volume of the fluid introduced in the vitreous cavity, but the chronic elevation is from the repeated injection is related to the obstruction of the aqueous outflow by direct obstruction by anti-VEGF molecules or indirect obstruction by scarring of trabecular meshwork from chronic inflammation or tuberculitis. So the management of the high IUB, in the early IUB elevation, usually it is transient, so it's because of half-life of the anti-VEGF is 3 to 4 days. So no need to start the patient on aggressive treatment. We can manage the patient with medical treatment. And also we will consider reducing the frequency of injection if possible. And also to consider medical treatment if the IUB is sustained and sustained high. And very important to check the IUB post-injection in patients with history of glaucoma with close monitoring. And surgical intervention also can be considered in controlled chronic IUB with failed medical treatment. Now we'll go to the high IUB post intravitreal steroid injection and implant. So the incidence is 16 to 18% of patients may experience high IUB more than 21 post 0.7 milligram Ozurdex implant. And 40% of the patient may develop elevated IUB more than 24 post a single injection of 4 milligram triamcinolone at 6 months and may last up to 9 months or longer. And the IUB elevation is dependent on the dose and the chemical structure of the steroid and the duration of the exposure. There are several factors may increase the risk of steroid ocular hypertension. It include pre-existing glaucoma and family history of glaucoma in the first degree relative, and also both in youth and advanced age, and patient with connective tissue disease and type 1 diabetes, and in also patient with high myopia. And the pathophysiology behind the increase of intraocular pressure following intravitreal steroid injection and implant is related to the increased resistance of aqueous outflow through possible mechanism, induced physical and mechanical changes in trabecular meshwork, and the second mechanism because of deposition of glycosaminoglycan in trabecular meshwork, and the third mechanism decreased breakdown of substance in the trabecular meshwork by inhibition of proteases and phagocytosis. The initial management of high IOP, it's involve discontinuing of steroid if possible, and also initiating topical and systemic anti-glaucoma treatment, and also patient post injection of implant or implant injection of steroid should be followed very closely, and the risk of IOP elevation must be considered before injection, and we need to check the IOP day 1 post injection, week 1 post injection, and with frequent follow-up if the patient at high risk of high IOP elevation. And also the use of SLT here showing promising result, and we can consider removal of implant if the IOP is uncontrolled, and also filtering surgery is recommended in cases that is not responding to laser and medical treatment. Now we will move to the silicone oil tamponade. Silicone oil is widely used in to provide long-term tamponade in retinal surgery. So the incidence of high IOPs range from 2 to 56%. And it's usually often as a mild and transient elevation of the intraocular pressure, and small portion of the patient may experience significant and sustained elevation of the intraocular pressure. The incidence of glaucoma that persists even after silicone oil is ranging from 8 to 10%. Although the risk factor of IOP elevation here is remain unclear, but several factors have been evaluated by a number of studies. So if the patient known to have glaucoma or MVG, they are at high risk, and also aphakic and pseudophakic patients, and also patients with history of uveitis. And furthermore, they found that if the patient have silicone oil or heavy silicone oil, they have high risk of early elevated of intraocular pressure. And if the patient have standard silicone oil, they have also late incidence of high intraocular pressure. Before we talk about the mechanism of glaucoma post silicone oil, we need to talk about the emulsification, which is a frequent complication associated with silicone oil. So the first one, the longer duration of silicone oil. The emulsification occurred 100% after 1 year. So it's recommended to remove the silicone oil before 1 year unless there is a risk of retina detachment. And the second point, decreased surface tension. So surfactant like serum, fibrin, it will facilitate emulsification by reducing the surface tension. And also low viscosity and low molecular weight. For example, if we have 5,000 centistalk of oil, it will be more resistant to dispersion and emulsification compared to 1,000 centistalk. And also use of perfluorocarbon liquid, it will enhance the oil emulsification. This is gonioscopic photo show infiltration of silicone oil in the angle because of prolonged duration of silicone oil inside the eye. There are several mechanisms of silicone oil related to glaucoma, which may be divided in two groups: early post-operative high IUB and late onset of glaucoma. Early high IUB it could be related to pupillary block and uncontrolled inflammation, or exacerbation of pre-existing glaucoma, or migration of silicone oil into the anterior chamber with mechanical obstruction of filtration. And for the late onset glaucoma, it could be related to the infiltration of trabecular meshwork by emulsified silicone oil, or chronic inflammation because of silicone oil, and synovial angle closure, and also reduced iridis, or recurrent pupillary block. So in the management, we should consider that the pupillary block is unique, that does not often lead to the flat anterior chamber. So we need to keep this in mind. And in aphakic and pseudophakic eyes, it is preferable to perform iridectomy inferior during the surgery to prevent this event. And it should be at least 150 to 200 microns. And when there is pupillary block despite the patent iridectomy, we should consider that maybe it is related to the improper size, too small or too large, or the location is not good, or if the silicone oil is overfilled. So we consider this possibility also. So in acute pupillary block, we need to instruct the patient to keep face down position to reverse the pupillary block, and then later we perform YAG PI. And despite all this precaution, 30% of the patient with iridectomy, it can be closed over time. And the treatment of silicone oil associated with glaucoma depend on the clinical presentation and the mechanism of the IUB elevation. Initial medical treatment, it shows successful control of IUB with only medical treatment, 30 to 78%. And the best management of glaucoma from silicone oil emulsification is to prevent it. So we need to prevent it by removing the oil before 1 year to prevent emulsification. And also early silicone oil removal with AC washout may result in normalization of the IUB from 68 to 93% of the cases. There is a study conducting here in KKH in 2020 by Dr. Al-Bahlal, and it is published in Journal of Glaucoma. They retrospectively evaluated 56 eye with refractory glaucoma after silicone oil, and that underwent CBC or glaucoma drainage device. And they found that both groups achieved a reduction of IUB and number of medication at 1 year, with successful rate of IUB control less than 21. In the glaucoma drainage device, 94.1%. And in the CBC, 53.8%. So if the silicone is removed and the IUB is still persistent high, we need to consider inferior placed glaucoma drainage device. So the success rate from 76% to 94%, as we show in the previous study. And if the silicone cannot be removed with high intraocular pressure, so we need to consider cyclophotocoagulation. Now we'll move to the last procedure, high IUB post intravitreal gas tamponade. So the incidence of IUB following intravitreal SF6 injection has been estimated to range from 6.1 to 67% of the cases, and it is also more in the C3F8 from 18% to 59%. The incidence is high in the C3F8 more than SF6 because it's related to greater maximum volume expansion and longer intraocular longevity. So the greater pressure elevation occur at the time of maximum expansion, 3 days for C3F8 and 36 hours for SF6. So there are several variables associated with IUB elevation. So the higher concentration of the exmesyl gas and use of C3F8 or older patient age, and also use of photocoagulation intraoperatively, or concurrent lensectomy done with procedure, and placement also of scalar buckle. The pathophysiology is from intravitreal gas injection due to the both open and closed angle mechanism. For the open angle mechanism, because of expansion of the gas, it will obstruct the outflow inside the eye, and when the gas also reaching maximum expansion, it can cause angle closure in the secondary angle closure mechanism. So this mechanism is related to the volume expansion in general. So in the management, the elevation of IUB is usually within first to 24 hours, and mild elevation in the IUB is usually respond to the topical treatment or oral treatment also within 72 hours. If the IUB rise is severe, also we can aspirate portion of the gases to normalize the pressure, and we will consider also laser iridotomy if we suspect pupillary block, and also glaucoma drainage device. It can be a good option if failed controlling of the IUB with long term. And also we need to keep this in mind. We need to instruct the patient to keep prone position and also to abstain from the air travel. So at the end of this presentation, we need to consider that the IUB elevation, either transient or sustained, is a common complication with retina surgery, and the risk factor is vary for each type of procedure, and the pathophysiology can be either due to the open and closed angle mechanism or both, and the mechanism of high IUB is highly influenced the management, and most cases of secondary glaucoma can be managed medically, and a small proportion of patients, they're requiring laser or surgical intervention to achieve the IUB control. And if surgical intervention is decided, the glaucoma drainage device is the mainstay surgery for the post-retina surgery. I think we finish the presentation. Thank you for joining today Grand Round, and if you have any questions, please feel free.
Thank you, Dr. Abdullah, for this wonderful summary on the, well, we have a full room. This is great. For this wonderful summary on risk factors in management. And I think that this is one of the main keystones. Please, come and sit here. We should be comfortable, or the way we won't think. And if anyone in the room has a question, we will appreciate, because we face this every day. Thank you.
Thank you very much, Dr. Abdullah. You did very
Welcome.
nice,
Thank you.
very nice coverage, at least the part I could reach and attend. Just to mention, probably you mentioned it earlier, and always there is really a very nice relationship between retina and glaucoma. And always I'm telling that it is like a marriage, but most of the time nice, but sometimes there are ups and downs. Now, also mind you that in acute retina, rheumatogenic retina detachment, the classic presentation of the patients is with low IOP.
Yeah.
But this is almost forgotten that also acute presentation can be also for high IOP. And this is known as Schwarz-Matsu syndrome, as you know, because of blockage of the trabecular meshwork by the outer segments of the photoreceptors. This is probably for the sake of the residents, just to mention this. And also, the main question is that the main cause of the acute IOP reduction in acute rheumatologic detachment is that excess drainage through the retinal pigment epithelium. And in fact, this is also done as part of a treatment. and this is mainly when in blind eyes, and there are studies done of large retinectomies exposing the RPE, but this led to some of the eyes to BVR and also complete detachment. But the main issue is really regarding the silicone oil. And I think the main factor, as you rightly alluded to, is the emulsification. And in fact, the higher the viscosity, the less the emulsification, the better is the IOP control or even prevention of this. And the other thing that you mentioned very nicely, that even after we remove the oil, because even with phakic patients, okay, some of these emulsified bubbles, they can travel through the zonules into the anterior chamber, and if we are careful, even with normal pressure, if we do gonio as retina, which are rarely done by us, but we can see these bubbles in the superior angle. And sometimes even after we remove the oil, we still, even with the, when you do retinoscopy, you see some of the oils still. And these, they sort of a storage of these small emulsified bubbles coming into the chamber, and this will continue to be deposited in the angle. And I think there is, yes, around 5-8% of chronic late IOP elevation after removal of the oil, which we tend to forget, in fact, as retina guys, and this is very nicely alluded to. One point regarding the gas, I think you rightly say that be careful of truffle. And it happened that one of the patients, not very well instructed, they mentioned only about air travel, but he traveled from Riyadh to Khamis Mshir, to Abha, by bus, not by air travel, and he wasn't aware that this bus, and when he reached there, the pressure was 70, it was so painful, but he went to the ER in the military hospital there, but their mistake was you should remove the part of the gas or send him down, which is very difficult, of course, and time consuming. But their mistake was they tried to do paracentesis. They didn't go through the gas. And if they go just 3 millimeters behind the limbus and just stick a needle, it will relieve everything. And they tried this paracentesis, and then all the lens came to the needle, developed cataract, and then they took him to OR. Once they opened all the gas and they pushed the anterior segment. So if you want to take the gas out, make sure to go through the pars plana, not through the anterior segment, and this is very important. But of course, the patients, we will instruct our patients, but sometimes we forget to tell them of high altitudes, and keep this in mind for all of us as well. Thank you very much.
Thank you very, very much for your input, Doctor. I agree with you. And also, I understand the point from the retina specialist that there is a risk of retina detachment. It can reach to 20% post-silicone oil removal. So, and also we understand that we can keep the silicone oil for like long term, more than 1 year. This is also in some cases with high risk of retina detachment. And I think also from the other point, we need to discuss the complication of glaucoma surgery related to the retina, like hypotony and the other part. Also, this is, I think, to give us broad spectrum of this relationship. But in general, it is friendly relationship in general, except this part.
Yeah, I agree. Now, also, to me, once we keep the oil for long period or indefinite, it means that we fail to fix the retina, to close the breaks. There is a problem. But sometimes, yes, you are pushed to leave it, but and sometimes we leave it to prevent phthisis, which is wrong. In fact, if there is the aqueous production is much less, we will have phthisis even with oil. It will be probably pre-phthysical and the eye is inflamed, but don't depend on the oil to keep to prevent phthisis as well.
Thank you. Your points are very, very valid, especially with the silicone oil that we face every day. Silicone oil is an oil, will reject the water from the trabecular meshwork, so there is no way that the water can leave the aqueous humor, but then also produce a chemical damage, histopathological damage that is probably related to this long-term high intraocular pressure. What will you suggest then in the daily activities when our colleagues from Retina or our beloved colleagues from Retina do the retina surgery and the next day call the glaucoma on call and say, I didn't overfill the eye and the pressure is 30, 35. What will be your recommendation?
Yeah, as I mentioned in the presentation, it is most of the cases respond to the medical treatment. So you can start by your own anti-glaucoma medication, and most of the cases it will respond to this medical treatment alone with no additional surgical intervention in the future or something. But we should keep this in mind. We need to rule out pupillary block. We need to rule out the every possible mechanism of high intraocular pressure. And I think this is a very important part. And we need to identify the patient at risk, so to keep follow-up closely.
Second step, do not respond 24 hours to the medication. And sometimes we hear, why do you don't go for a micropulse CPC?
Yeah, it's difficult to go for this procedure at the beginning. Still, the eyes now present with post-op inflammation, and the IOP is expected to be high in this stage in most of patients with, for example, pre-existing glaucoma or familial history of glaucoma. So we will wait, we will observe, we'll keep the patient with the maximal treatment, and we'll close observably to see what's going on. We need to identify the reason, actually.
Any question from the audience? Yes, please.
Because now we are injecting more and more intravitreal ozordex and also other types of cortisol of steroids. Now, do you agree that to the notion that probably most of us will develop steroid-related glaucoma after very long use, or is it just probably those at risk of developing? And now, the first visit, when do you expect the pressure will rise? For most of us, they will come after 3 weeks, 4 weeks to check the IOP. Could you have an earlier rise of pressure related to corticosteroids, not the volume, but because of the steroid responding itself?
The risk of steroid responder, usually we will see it in the young patient or the old patient. This is the range of incidence of high IOP post-steroid. And regarding the duration, can be happened from the first injection alone, as we mentioned in the presentation. But the presence of high intraocular pressure can be seen later, after like 3 weeks, 4 weeks, and 3 weeks. Usually it's from 3 weeks. Steroid responding at 3 weeks in general. It's reaching up to 6 weeks. We will see that if there is steroid response.
I guess that is very important, the sensitivity of the patient. Always traditionally have been saying patients with primary open-angle glaucoma or relative of primary open-angle glaucoma patients that goes for steroid use, no matter what kind of use, topical, intranasal injections or implants, can develop this high pressure usually the first time 6 weeks after the exposure to the steroids. But if these are patients that has been on chronic use, usually that break or that presentation can be shortened. So I know a little bit, I'm thinking that your point is related to those cases that has been under steroids, and then suddenly if we should be aware of an evaluation earlier. Probably if the patient has been submitted to steroids for a chronic use, yes, I would suggest maybe 2 weeks before or after the procedure, the pressure should be checked. Agree with me?
Yeah. Also for the topical steroid, we need to check, for example, after 3 weeks. usually the patient will, if the patient are steroid responder, they have elevated intraocular pressure in this period of time after 3 weeks. So for topical steroid, for example, we need to switch it to weaker steroid. But for Ozurdex, for example, it is difficult if the patient have glaucoma or advanced optic nerve damage. So because of that, we need to identify the risk before we go for this injection or implant. Yeah, I think this is the most important part, because in every procedure I mention risk factor, because it's very important to check it before we go for like any procedure of retinal procedure.
Do you recommend to child having topical forces to know that this patient will develop steroid glaucoma after the implant or no?
Actually, this is...
May I add something? Steroid responder was linked to many genes that linked with primary open-angle glaucoma. So if you have a patient for a steroid injection you would like and have a family history of primary open-angle glaucoma, try to avoid it. I think the doctor idea about, because he's a steroid responder, so maybe he will take a crash course of like a strong topical steroid for a month and check before the injection. This was also my question. Yeah, like a challenge test. What do you think?
You mean to put the patient on steroid topical before
QID
thinking on injecting the Ozurdex,
exactly,
for example,
exactly.
right?
Because once you put the Ozurdex, there is no removal.
It's a very interesting topic to discuss, but I think here the role is on retina, because I believe that if you retinologist think that the patient needs the intraocular Ozurdex is for a particular reason, and if he need it, probably, this is from the glaucoma perspective, probably I should say, if you consider, go ahead, because the macula is jeopardized and the vision is in risk. As a glaucoma, if the pressure start to rise, don't worry, I will put a tube or whatever is needed. This is what I will tell you if you ask me about this patient needed Ozurdex.
But then doing, like, tomorrow he will end up with the retina disease, Ozurdex is left the eye, and we'll keep on managing the surgical glaucoma surgery that we have done, and many of them will go into hypotony after, like, if the uveitis cleared or anything. And so it's preferably if we avoid it, especially they have a lot of things other than Ozurdex. Yes, you
but
can.
Do they have a lot of things other than Ozurdex?
Now, at least we leave Ozurdex as the last resort.
Yeah.
Yes.
So sometimes we...
You don't have an alternative. Okay.
My one thing is sure, Abdullah trabeculectomy will work perfectly after Ozurdex implantation.
SLT
Yeah,
works
but I
also.
prefer. Yeah, but I prefer the tube actually.
Why I say tube? There are different options now, and tubes are good. We have a way of regulation. Trabeculectomies are also good. We have a large vademecum. It will depends on our choice.
Yeah.
And no harm in trying SLT before going to surgical. May I ask about the silicone oil? So if we, from the first day after the silicone oil injection, the pressure was high. Isn't preferably that, this means that it's overfilled the eye, and silicone will stay there for a year or so. So why should we give aqueous suppressant? Cannot you like remove a little bit of the silicone next day easier than treating medically with aqueous suppressant? Because this will change the dynamics in the anterior segment, and you already have silicone will come in front, and I don't know, it's just an idea. Isn't it better to remove some of the silicone?
Maybe if it is proven that it is maybe an element of pupillary plaque, or if you eliminate all other possible mechanisms, probably yes, overfill. But usually, once at the end of the procedure, we in fact make sure that the pressure is okay and with a good depth of the anterior chamber, so that we are very careful about this. So it is the overfill of silicone oil. I think it has been given much more than what it deserves. But sure, I have seen cases that yes, it is there is overfill, and in fact, you will just if you remove little as little as probably 0.1, 0.2, then you will, because as you know that the volume of the anterior chamber is only 200 micro. So this is, probably it is very good, because now the patient will be entitled for chronic anti-glaucoma medication. And if we rule the acute causes of, as you mentioned, the inflammations, the pupil block and all this, and I think this is very good, and it's easy to do it, very easy.
Yeah, I agree with you, doctor. And also, if the patient presents, for example, after silicone oil post-surgery with good IUB control, and later he develop, like 2 to 3 days, he develop high intraocular pressure, most likely it is not silicone oil overfill.
Absolutely.
Most likely it could be related to inflammation and controlled inflammation. And we need to start the patient on BRIT 40. We need to start the patient on equisuppressant. And we need to check also if there is element of pupil block, because it is unique. It is not flat anterior chamber usually. It's like the normal pupil block. We can see there is depth in anterior chamber. So some people, they are thinking it's overfilled. Actually, we need to rule out pupil block in this case.
Thank you. Dr. Adania, please.
Thank you, Dr. Abdullah, for this nice talk. I have 2 comments. They're more than questions. I think we are underutilizing 2 important things that you mentioned beautifully. One of them is surgical PI. Like, there's a saying that says whenever you go inside the eye, do PI. So like, there's no harm in that. If you're gonna do a PPV, at least you will eliminate the secondary etiologies of having a high pressure. And a good, decent one would solve a lot of issues, like maybe more than 50% of the time. The second thing that is underutilized. Yes, because as he mentioned, not necessarily it's only the AC depth, it's a complex mechanism of a lot of pathologies. So not only like a pupillary block, a lot of elements can play a role in that, even with the presence of an IOL. Yeah. And the second thing that is also underutilized is referring patients for clearance before Ozurdex injection, because sometimes you can have somebody with advanced glaucoma, which is like would do more harm than benefiting such a patient. I like to see patients referred to my clinic for pre-injection evaluation. That would be really a good thing. No, talking about specifically glaucoma patients, yeah. Thank you.
I agree with you. A great idea to have this, I mean, to be the patient to be checked before going for the long process of a steroid, for example, Ozurdex. And yeah, I think we can apply this in also in our clinic to make sure every patient will have good control of IUB later.
Any other question from the audience? Dr. Anobilati, for sure you don't want to say anything? We will appreciate any of your comments as always.
Well, no real
Okay,
questions.
wait. We want to hear on the microphone, if you don't mind.
Yeah. First of all, I'd like to thank you again for presenting this. I don't really have particular questions, and a lot of the things were said before. I just think that, as you mentioned, glaucoma is going to be different according to what you have done. So, for instance, you started with saying, okay, what's the risk of glaucoma in PPV? All right, now PPV by itself, I don't think the risk of glaucoma is very high by itself. But if you start adding things, like membrane peeling, a lot of steroids, a lot of laser, you're creating more inflammation, and therefore, you're creating the background to develop the high pressure. And so on. And it's going to differ whether the patient is phakic, whether the patient is, decompartmentalized, with no lens or a pseudophakia. That's going to differ. And it's going to differ according to the positioning. If you have a patient that, for instance, you have done a vitrectomy for, and were obliged because there was a significant PVR to do a 360 laser, apply gas, put the patient face down, you can be sure that the next day there's going to be glaucoma, okay? But if you have a patient who doesn't necessarily sit face down or sleep face down in the first day, that glaucoma is less. And that's because all that inflammatory junk is going to go from the posterior part of the eye towards the trabecular meshwork, and it's going to clog your trabecular meshwork for about 5 days. Okay? And then things go settle. You give anti-glaucoma medications, as you said, and things will be temporary. As far as the anti-VEGF pressurize, of course, whether you inject water after, or triamcinolone or Ozurdex or what have you, or any kind of injection, you're basically injecting into a closed system. So you're going to create high pressure on the spot. But, alhamdulillah, the eye takes care of it. Within half an hour, pressure comes down, and that's been documented. But for the long-term IOP rises, it differs a little bit, not just between ranibizumab and Avastin, but it differs also according to the pathology. Like, for instance, Bailey Freund has studied this extensively in patients with AMD. Okay, and the risk there is between 5 and 10% of patients that have more than 15 injections done to their eyes. Those will have some rise of intraocular pressure, which is usually well managed with just with topical medications. We did a similar study, but not on AMD patients, here at KKESH with Dr. Abdullah AlZahrani when he was a resident as part of his thesis. And we found out that in diabetics, which usually are younger, than patients with AMD, the risk is less. Okay, so it's not just the injection, it's also the age. And as we know, as people get older, they also have a higher tendency to develop glaucoma. So it's really a very complicated, area. You cannot just pinpoint saying, okay, it is just the injection, or it's just the age, or it's just the amount of PRP that you've put in the eye at the end of surgery, or whether it's an overfill or an underfill. It is more than that. It is really complicated. But I think if you anticipate that a patient is going to have high pressure, you will be inclined to do whatever it is necessary to that the patient doesn't have it, or lessen the probability. That's it. But it's exciting.
Thank you.
Thank
so
you.
It's at 3 o'clock. It's a very interesting discussion.
Because she said
short
volume, volume, glaucoma. If you inject volume, I think in advanced cases of glaucoma, when I inject into the eye, I will not let the patient goes out of the injection room until the pressure is normal, even up if I need to do AC paracentesis.
Thank you. Very interesting discussion. Remember, glaucoma suspect and hypertonic eyes are not the same. It's all regulated by the optic nerve, and that makes us and our conduct change. Thank you very much. I think that we should open a second chapter later on for a glaucoma and retina session. Thank you very much to all.